evening, everyone. In the interests of time, I think we'll get started now. We've got quite a few participants in the room already. So welcome to our Emerging Business Trends in Primary Care education sessions. This is the first of 4 sessions we're planning over the next 10 months. And the topics tonight are health reform and change management. My name's Tricia Rayner. I'm the manager of the Primary Care Quality Improvement team here at the Northwestern Melbourne Primary Health Network. And I'd like to start by acknowledging the lands on which our work takes place. The Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woiwurrung people, the Boonwurrung people, and the Wathaurong people. We pay our respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Just a little bit of housekeeping for you all. All attendees are muted. Obviously, we've got quite a few people expected tonight. Questions will be asked via the chat box, and we will have a short session after our first speaker, but then we'll have extra time for questions at the end of this session. This session's being recorded, and all participants will get a copy of the recording after the session in the next few days. Questions will be asked anonymously to protect your privacy. Now, with us tonight, our 2 presenters are Gary Smith, AM. I'll let Gary explain all of that to you. Gary has over 36 years of experience in managing healthcare practices. Famous for Coffee with Gary, I think is the correct one. He's a former national president of the Australian Association of Practice Managers and was awarded life membership for his significant contributions. Gary chairs multiple organisations, including Quality Innovation Performance, so QIP, and I think a lot of us are very familiar with QIP, and Wentworth Healthcare, and serves on the board of AGPAL and General Practice Workforce Tasmania. Gary's involved in several government advisory groups and is on the executive board of the Asian Society for Quality in Healthcare. Additionally, Gary is an academic director at Uni Partnerships, an ISQA expert since 2017, and has been a surveyor for AGPAL for over 27 years. I presume from that perspective, we'd all love to get in his ear. We also have Riley O'Hanlon here, who has extensive experience in healthcare standards, compliance and accreditation. She previously served at AGPAL's Client Liaison Officer for New South Wales at ACT, where she gained expertise in areas like clinical governance, infection control and risk management. As National Manager of QIP Consulting, Riley has led the development of standards, resources and gap assessments for organisations across Australia. She's passionate about standards review and development and has contributed to creating internal quality frameworks and national standards. With background in pathology, Riley also focuses on mental health, multiculturalism, domestic violence and suicide prevention. Her approach is patient, collaborative and client-focused to drive lasting quality improvement. So just a brief overview of the upcoming webinars. The next one we're hosting under this series is Payroll Tax in Victoria and Practice Viability on November 13th. Next year we will have 2 sessions, one on AI and security confidentiality and privacy, and the next one, the one after that will be on workforce and recruitment, around about February and May for those 2. And without further ado, I'd like to hand over to Gary, and I'll stop sharing, Gary, if you'd like to take over. Thank you.
Thanks very much, Tricia. Now the question comes, how do I think this could be all okay. How does that look?
Yeah, nailed it. Beautiful, Gary.
Oh, thank you very, very much. I might have all those that intro thanks very much for the intro, Trish. My IT skills may need a little bit more work on, but thanks very much for your introduction. Some of you will know me as a Coffee with Gary, which I think the next session is coming up on December sometime. But the AM after my name was, as Tricia said, I was awarded an Order of Australia, an Australian medal in the King's Honours list in 2023. And that was really because of my commitment to medical administration and to professional organisations. And I, like Riley, have a view in life is that the knowledge we've gained is not for us to keep. We just happen to be lucky sitting in environments whereby we have an ability to gain access to information from things called sources of truth. And I think that's the important bit. And I think tonight, the bit that Riley and I are going to talk about is really around where the sources of truth are. So part of my presentation is going to be, what does our healthcare system look like today? And what's it actually going to look like tomorrow and in the future? So in having a look at that, this particular slide looks complicated, but when you have a look at it, it's really the future of primary care to 2030. I'm going to take you through some documents today that's going to say what's the future look in 2032. But if anyone's been in practice management or in primary care longer than 5 years, you would have seen quite a bit of change. And all I'm going to say to most of you now, if you think we've had a lot of change in the last 5 years, and I honestly say to you, you ain't seen nothing yet, because we've got some big challenges for the future in relation to what our healthcare system is going to look like. In relation to the presentation tonight, we're going to cover off on some key principles and frameworks around what does the future look like. And it's going to be around place-based care, things called integrated team management, community-controlled primary care, voluntary patient registration, alternate funding models, and that's going to be based around sort of block and bundling models through assessment. Now, as we work through the presentation tonight, you're going to see some slides with a star on them. Those stars are the slides I think you need to take pretty good notice of, because I'm going to highlight some key points of what you may need to think about. So what tonight we're going to talk about? Well, a lot of you may have seen this slide before. This is Bodenheimer's 10 building blocks for high-performing primary care. Now, your PHN would have seen this. You may have played with it within your practice, but there are 10 building blocks. And dare I say it, that these 10 building blocks are really, when you look at it, are part of the framework of our healthcare framework for the future. I'll give you an example. Building block number 3, patient registration. Yep. Voluntary patient registration, MyMedicare. We're here on that now. Data-driven improvement. Yes, we're going to see some changes in relation to information technology and what data is going to do for us in the future. Population management. We're going to find that in population management as well, a lot of our funding is going to be based around what our population management may be. Engaged leadership is going to be an important part as well, and Riley's going to talk about that later on. So what's the big picture look like? So tonight I'm going to talk about a number of reviews in the framework. We're just not going to talk about MyMedicare tonight. MyMedicare is only one part of a big picture of the reform for healthcare. A little bit like when GST came in, if anyone can remember back that far. We just thought, oh yeah, GST is going to come in and it's 1/11 of the value. But little did we know that GST was a complete restructure of the tax system. PAYG, PAYI, all those other components BAS statements. So it actually became behind the scenes became a restructure of our healthcare, and we thought we were only going to deal with the 1/11 component of value. So every one of these reviews that are on the screen now are going to have an influence in relation to what our future healthcare may look like. So what is happening at a government level, both at a Commonwealth, I might add, and a state as well? Now, I'm going to touch on each one of these: the incentives review, the scope of practice review, the National Health Reform Agreement, that's a whole of government approach across Australia. Working Better for Medicare Review, MyMedicare Framework and Voluntary Patient Registration, and the GPACI Framework or the Aged Care Incentive Framework. I'm going to touch on each one of those tonight, just so you get an indication of what does this mean for us, rather than just the fact of MyMedicare is one piece of the jigsaw. So let's have a look at the review of general practice incentives. Now, as we go through here, I'm going to put some references in here, and the PHN are going to provide a fact sheet after the presentation tonight, and in that fact sheet will be these particular links for you. So you may or may not be aware there's been a review of the general practice incentives, and there's been some questions being asked whether the PIP and WIP promote patient-centred multidisciplinary care, and there's two reports on this, one by KPMG and the other by a task force, and both of those are out for comment now. And the incentives review looks at ways to design a new blended funding model to better meet the changing primary care needs, especially in relation to the increased growth of complex condition. I flagged that second point there under the review of general practice incentives is really important, because that document provides the framework of what our funding mechanism is going to look like in the next 2 to 5 years. I don't know if anyone's had a look at that report yet. It's a 78-page report, but I would suggest that you take the time to read the executive summary, because it really provides what's going to happen with incentives and the MBS. And I'll talk a little bit more about what I think is going to happen towards the end of the slides. The next one is a scope of practice review. Now, the scope of practice review looks at allowing staff or people within our healthcare system to work to top of scope. We know full well it's hard to get clinical people. It's hard to get non-clinical people. The whole aspect of registration and credentialing is a challenge in our healthcare system with overseas trained doctors, and just the process through AHPRA, etc. Professor Michael McCormack has now produced the scope of practice review, has been out for comment. I think the first 2 iterations are out, and it's just about to land, if it hasn't already, on the minister's desk. But there's certain things which are going to come out of this scope of review. I flag with you, and this is going to be around new roles emerging, and we've got to start to think outside the box. What may be some of these new roles emerging in primary care, taking into consideration the new healthcare delivery model, which we're going to have around multidisciplinary care. But part of the scope of practice is talking about the right technology, innovation, and regulation. So here is, for your information, what the scope of practice looks like in primary care, what are the focus areas in primary care, and what may be the risks associated with. So in the primary care workforce, he looked at general practitioners' role, nurses' role, midwives, pharmacists, Aboriginal and Torres Strait Islander practitioners and workers, allied health, and paramedics. Now, under each one of those areas which he looked at in relation to the scope of practice, or he and his team, there were a series of 6 focus areas. He looked at legislation and regulation. He looked at technology, the use of technology. Education and training, that's a good one. You know, what we need to do for education and training to upskill people. What are going to be some of the funding mechanisms for the primary care workforce? What it means for us, practices as employers, and where does leadership and culture fit into this? Now, once again, this is a very detailed report. As I said, if it hasn't landed on the minister's desk, but it will be in the month of October sometime. But if you want to go back and have a look at some of the consultation papers, and I've given you the link in the previous slide, it just provides you a really good insight in relation to what is the future skill sets and knowledge we're going to need in our current workforce structure, and how do we allow our staff to work to their scope. I'll just give you an example, for instance. Medical practice assistants, MPAs, are identified in there. How do we upskill our non-clinical staff to do certain clinical roles? which allows nursing staff then to increase their scope of practice as well in your organisation. So there's some good frameworks in this particular document. This one here is the National Health Reform Agreement, or the NHRA. Now you say to yourself, well, what does this mean in relation to hospitals and the state and the federal and state government on this? Well, the NHRA, which is in the process of being worked through now, actually includes now primary care, PHNs and local government. This is around how we at PHN level, general practice level and local government level, how can we work towards keeping people out of hospital? It's called hospital avoidance. And I'm going to talk about a program that fits perfectly into this hospital avoidance under MyMedicare in a moment. But this is, we haven't seen the involvement of PHNs, practices and local government in the NHRA agreement ever before. So this is a joint government decision. The next one is Working Better for Medicare Review. Associate Professor Mick Reid is leading this particular review. And this talks about the effectiveness of our current distribution levers in relation to things like 19AB, 19AA, workforce classifications, especially DPA, DWS, and the Monash modified model classifications. And Mick Reid and his workforce currently are looking at what does this look like for this particular review as well. So there is his distribution levers, which I just spoke about in that top line, and there are certain objectives that his advisory work group need to look at. Objectives, evaluations, alignment of workforce policies, what are the inhibiting factors for all those, quality improvement and opportunities, and identify future role of distribution levers. And part of this is also around looking, as I said, M ratings, the Health Insurance Act, distribution priority areas, distribution of workforce shortage, etc. So as you can see, this is just one of those other frameworks which are they're working on now. Has everyone gone to sleep as yet? Trish, are they all still awake, are they? Might be a bit boring, but is it dry?
Can't see anyone, Gary, but you know, I'm finding it really interesting. So, you know,
thanks,
everyone
Trish.
else should be too.
They should be too, yeah. The only reason I'm just flagging these first few slides is just to give you a big picture of what we're up against, what government are up against in relation to the reviews which are taking place. They're all going to have an influence on the future primary care framework, as in the framework of primary care. Before we even start to talk about these other programs, which I'm going to talk about now, which I'm going to touch on now. And the first of the where is the government up to in the frequent flyer program? Do you know about the frequent flyer program? No, this is not with Qantas or Virgin. This is a frequent flyer program. These are, they're in the early stages of developing what's called wraparound services for frequent flyers to hospitals. Now, they're wanting to identify these frequent flyers that have multiple and complex health needs. You know, there's 10, I think the last figures I saw, there are 10,000 people in Australia that attend accident emergency more than 10 times in a 12-month period. They're quite frightening statistics. And this is what government are really concerned around this frequent flyer. So how do we keep these people out, or how do we get them out of the hospital system? Well, the frequent flyer program is going to be piloted across 8 or 9 PHNs. And I don't know whether these 8 or 9 PHNs have been identified as yet. They may have been, but it's all very hush-hush and quiet. These 8 or 9 PHNs are going to be trialling this new frequent flyer program. And how does it work? Well, it means this is where state, Commonwealth government, state government and PHNs are working together. The hospital will identify the frequent flyers. They'll be referred to the PHN, their name will be. The PHN will ensure that they need to be registered under MyMedicare in a MyMedicare practice. then that practice and or practitioner will take the management of those particular patients who have been identified in the frequent flyer programs. Now, for that, the practice will receive a fee, an incentive to do that, and then the practitioner will receive an incentive to do that, to manage it, and there will be possibly MBS item numbers around that as well. So this is the first of the programs where Commonwealth Government, State Government and PHNs and general practice or primary care are going to be working together to manage those patients that have been identified with multiple and complex health needs. Now, the numbers that I saw about 18 months ago, the dollars and cents, I'm not going to quote them because they possibly changed by then. And thanks very much, Tricia, for that disclaimer at the beginning, saying that the information contained in this is our current as at today. But they were really good dollars. And I mean, they were thousands of dollars to look after these patients. So this is a frequent flyer program. They're saying by 2026, the last that I had heard, that they'll be rolled out across all PHNs accordingly. So that's part of the NHRA I was talking about, where the Commonwealth and the state governments are working together. So why have they, and what were their findings when they looked at this particular program? They wanted to establish a single point of contact for these frequent flyers. They then want to develop individualised care plans for these frequent flyers that could be managed. Then they want to put in place providing support and then coordination. This is the reason, what their findings for when the basis behind the program. So that's the frequent flyer program. Your PHN may or may not be part of the initial 8 or 9 PHNs. I don't know, but that's just flagging for you. By 26, it'll be across the 31 PHNs across Australia. This is a concept you've got to get clear in your mind. Our healthcare system is moving from volume to value-based healthcare. Volume to value. If there's only 2 words, well, that's 3 words, volume to value, isn't it? I was never good at maths. 3 words you take away, volume to value. And you're going to see in a moment about, when I give you some statistics and figures, of what percentage of your income is going to come from volume and what percentage is going to come from value. And the government have made this public. So I'm going to give you those percentages in a moment. So when we're talking about a value-based healthcare system, there are 3 principles. So the 3 principles are patient-centered care. That's what voluntary patient registration is supposedly all about. Have we been doing patient-centered care? Maybe we have, but we've got a few more steps which we need to go through to substantiate patient-centered care. The second principle is measurable health outcomes. If it can't be measured, it never happens. So we're going to start to think about value. So how do we measure value? So that's one of the principles. And the third principle of volume to value-based healthcare is payment reform. The days of ka-ching, ka-ching item 23s are going to be a percentage of your income. So, and I'll talk about what that percentages may be. So for volume to value-based, based care, payment reform is critical. These 3 principles the government have put into their framework in relation to the future of healthcare. This is a star slide. So let's think about this. Volume to value-based healthcare requires all healthcare organisations to advance our thinking and to plan and formalise infrastructure in 3 areas. So we have to go back and redesign and re-engineer our thinking, and Riley's going to give you some hints and tips later on of how you may do this. But value is about reframing our thinking away from the traditional way of thinking of volume to value. So when we're talking about volume to value, we need to start to think about our organisational capabilities. What can I deliver? The structure we have tomorrow will not be the structure we had yesterday. Under volume, we had a very operational, task-driven process, but under value-based, it's a completely different organisational structure. The other area we have to start to consider about is provider engagement. Provider engagement. Is that the GP? Well, it may or may not be the GP. It could be your nurse practitioner. You could be your nursing staff. It could be your medical practice assistant. It could be your receptionist. It could be allied health on site. It could be a whole range. Part of value-based healthcare is about provider engagement. And of course, the last one in shifting volume to value-based healthcare is around the engagement of patients, family, and community. Remember the concept of patient-centred care. It is the patient. They're the centre of the care, and everyone else around is part of the patient-centred team, whether they're in-house or out-of-house. And that's where generally our medical practice as an organisational has been around the clinician or the doctor has been the centre of care. Well, we have to start to rethink about that. And somehow there has to be a funding model that takes the doctor out of the centre, puts the patient in, then the multidisciplinary team becomes the people who drives the changes. So let's have a look at blending brings benefits. Well, there are in blending payments and the blending system, there are definitely clinic and clinician benefits. This could be as a result of incentives which are paid for doing the work without item numbers. Those incentives may allow the employment of other people directly or indirectly in the care. There's going to be more funding for more complex patients. So there's going to be some benefits around that. And financial rewards for efficient and effective care. Yes, I think you're going to find there's going to be, at a given point in time, payments for around how effective our care is. I'll give you an example. In Western Sydney, I think our diabetes rate is 25% of population, with maybe 12.5% for the national population. I could have those figures wrong, but I know we're 25% in Western Sydney. So I'm going to be looking at possibly programs in my area to be able to attract funds around complex patients because of their diabetes. So there are some benefits to the system and patient benefits as well. The system is around continuity of care, and that's what MyMedicare is all about, and voluntary patient registration will be about. Patients' benefits, there is a team looking after them rather than one person. Patients' benefits are going to be about prevention. And I think the big one about this is health equity. There's going to be a greater health equity in relation to this whole blending brings benefits. And I think this also links into what I call health literacy and systems literacy. Two very important parts in the new funding model is health literacy and systems literacy. Right, what do I move on to now? Oh, there's another plan. Oh my gosh, here's another document. This is another document that is our 10-year plan. That's the vision of government to the year 2032. It's a great document. Well, I think it is, because it actually sets some framework for us. And this is a comment made by the Minister. Australia's health system delivers some of the best outcomes in the world, and the continuing adaptability, responsiveness and skills of primary healthcare workforce plays a fundamental part. And the continuing adaptability and responsiveness. This particular 10-year plan addresses what I just spoke about. So what are the objectives of the 10-year plan? This is the vision of government. And I'm not going into too much detail of these 10-year plans, but there are a number of areas that the government have addressed in this 10-year plan, in their framework. Access, close the gap, keep people well, continuity of care, integration, future focus, and safety and quality. I'd like to come back to future focus. embrace new technologies and methods. You are going to see some sizable changes in availability of technology and methods of how we deliver services. Government are going to invest very heavily in ICT, of which we will benefit from. As you know, just an example, My Health Record, the Australian Digital Health Agency, has been given $1 billion to upgrade My Health Record. And you're going to see some massive changes in that. I'm going to give you my insights later on of what does the new My Health Record and the new care plans may look like for the future. But each one of those objectives, or those 10-year plans, provides some framework around what we may need to look like. The biggest thing for the objectives of the 10-year plan is really in the roles of Aboriginal medical services. The plan refers so much to Aboriginal medical services and how they deliver services across the community. So if you want to see what our future looks like, what the government looks like, please read those 128 recommendations. But you can skim through them. It's a very good vision of what our future healthcare looks like. So part of this the 10-year plan, which I spoke about. So why patient-centred care? And this comes from the Safety and Quality Council Commission of what is the foundation of person-centred care. And I think when we start to think about person-centred care, we need to think about better patient and community experience, better workforce and experience, better clinical outcomes and safety, and better value care through lower costs of care. And when I look at these four main areas, you can see the role that this is playing in the reports which are being produced and have been produced by government. So what are the key attributes? It's actually person-centred care is really about achieving safe, high-quality care for patients. And this is what person-centred care is really all about. And the important thing about this is that you as a leader have an essential role in ensuring that the organisation delivers person-centred care accordingly. And as I said, Riley will talk to you about this in a moment, and what maybe she can provide some skill sets around that. Well, here's another report for you, another one. This was the last one, December 22, which the Minister himself, Minister Butler, actually chaired this particular report. And a lot of these recommendations in this report from the 10-year plan and the MBS Task Force review from 2016 to 19, which I sat on, are coming to fruition now. And I'll give you a slide in a moment of what's happening on that. But there are 4 pillars in this report. So this is a fresh one. Increase access to primary care. Pillar 2, encouraging multidisciplinary team-based care. Pillar 3, modernising primary care. That's a good one. And Pillar 4, supporting change management and cultural change. And that's why the PHN were interested in getting Riley on tonight to talk around what does Pillar 4 mean and what do we need to do this. So just quickly, I'll just touch on Pillar 1, increasing access to primary care. A number of these things government has started to do in Pillar 1. They've started to look at a blended funding model. They've started to look at voluntary patient registration. They've looked at new funding models other than MyMedicare. And they're looking at the after hours as well. What does that look like through EDs and through, which is urgent care centres, which has through the WIP. And they're doing, in the incentives, one that they're doing review now is the role of after hours in our practice. So a lot of Pillar 1 is already happening. Pillar 2, 1, 2, 3, 4. The first 4 are recurring now in the reviews. And the last one, dot point number 5, is occurring now. So all of Pillar 2. Now, this was 2022, this report was put out with these recommendations. So you can see the government are working on these. So all those dot points really I've put up for Pillars 1 and 2 are either happening or in the process of happening. Pillar 3, modernising primary care. Modernising My Health Record, definitely. That's why they put $1 billion into this now. Sharing by default. They're changing the opt-in, opt-out. We're seeing this now going to happen with pathology and X-ray results. That is going to change. The minister has made a public statement around this as now, where they'll automatically go up to radiology and pathology will automatically go up. They're going to put some more requirements around legislation around including software. Primary care IT, they're going to give us a lift up in that. But the big one, I think, for us is what does the PIP-QI going to look like? And just watch the space for our PIP-QI. Where is that going to sit for the future? Is it going to be in the same format that it's sitting in now? Or is it going to roll into, is it going to go? Or is it going to roll into other incentives accordingly? So there's a lot happening in the IT data component for us. I can't say too much, but the ICT component framework is out there now. It was put out about two weeks ago. They have summoned the software vendors together in relation to what they are going to need to do with the changes of their software to modernise us in relation to data extraction and data uploading. So just keep an eye on that. And Pillar 4, support change management and culture change. The second last dot point is a good one. Support practice management as a profession, including through an initial training program to help practice transition to new ways of thinking. This is going to be a role for PHNs in this, or whether PHNs outsource this to an organisation to do this through the PHNs, but that's going to be a big part of the PHN Pillar 4 in relation to transitioning of healthcare to reform. Because we say to government, as you'll see in one of my slides in a moment, there's no use putting into place reforms if no one knows how to do it. So let's talk about voluntary patient registration, which is Bodenheimer's building block number 3. So, you know, where we've heard this term, my medication. I think we need my medication. My Medicare. So what does MyMedicare do? It has the potential for a whole range of things. And I've touched on some of these. And I think it will improve patient outcomes. And I'll talk a little bit more about, you know, what is the personalised and coordinated experience are going to be in a couple of slides' time. I actually think it's going to reduce administrative burden. You may not see it now. We're in this transition period, but government have said that MyMedicare is a 2 to 5 year program. Right? So we've got another... You know, we've got 2 to 5 years to embed all this accordingly. It's going to provide enhanced financial viability if we adapt to a new way of thinking. If we don't move our traditional thinking to the new way of thinking, we're going to be struggling in relation to financial viability. And of course, the last one, of course, with MyMedicare is strengthening relationships between the patient and now, the challenge we've got, of course, is that, you know, I'll talk about this in a moment. You know, what are the benefits? We're struggling hard to make this worthwhile to our patients. I'm going to give you some tips in a couple of slides' time. But it actually has the potential for improving staff morale by providing certain tools and resources to staff for them to do their jobs effectively. So you're going to see some tools which are going to... we hope that it's going to reduce the burden to hospitals. And provide those incentives for us to manage those patients rather than the hospital manage them. We hope access will increase access, especially in the rural and remote areas as well, with them through telehealth services. And we'll talk a little bit more about what does that look like for the future in a moment. And hopefully MyMedicare will support innovation for us all. MyMedicare is not a complete replacement for Medicare. It is not a single-payer healthcare system. Oh, that's good. Sounds like we've got a budding practice manager on board, Tricia. I want to go...
Yes, there you go, Gary. She'll keep you on your toes.
Thank you very, very much. I do appreciate that. I want to go back to what it's not. A complete replacement for Medicare. Now, this is an interesting one The government have said under the MyMedicare system, you'll receive 60% of your revenue from MBS item numbers and 40% from incentives. How's that? 60? Oh, I can see people writing those percentages down now. If we can go home, we can go home now, Riley. I think we've got the main information out now. 60-40 split. MyMedicare is going to be 60% MBS item numbers and 40% incentives. So how does that sound in relation to our traditional thinking? If we're going to rely upon the ka-ching, ka-ching, ka-ching of item 23, think again. This is why it is so important for us to think about those three words. I won't ask you what they are because you're on mute, is volume to value. That concept of volume to value fits into the 60-40 split. So MyMedicare is laying, I think, the foundation for what? Well, may not today, but it's laying the foundation for a number of things for the future. New incentives, new technologies, new models of care, a restructured Medicare system. But MyMedicare is really about the formalising of the relationship between patients, their general practice and their primary care team. Government want the relationship between a patient and a practice and a practitioner. So how can MyMedicare benefit a practice? Well, you may not think of this at this point in time, but the big picture is improved patient outcomes, increased and the traditional. So what do we know so far? Well, what do we know? We're moving from value over volume-based system with incentives. We know about the voluntary patient registration for MyMedicare. We already know that there's already been incentive programs introduced for practices that are registered through MyMedicare. There are MyMedicare programs which have been identified but not yet commenced. We know the chronic condition management plan process has been deferred to 1st of July 25, and there have been item numbers identified for the preparation and management of patients in chronic disease, but no values at this point in time. So what else do we know? As from November the 1st, 26, a new GP chronic condition management plan will be required for ongoing access to allied care. We also know from November 26, a GP chronic condition plan will be required to access to domiciliary medication reviews. So item 900s are going to go as standalones. So what does quickly a chronic condition management plan look like? Well, it's going to replace a GPMP with a single chronic condition management plan. Notice the change of words. Supports continuity of care, and they'll be able to obtain this from patients registered in MyMedicare in the practice or through their usual GP. The management plan is going to equalise the fees for developing and reviewing plans. Over the life of the plan, with the reviews, they're saying they're going to equalise the fees that are currently in place now. They're going to require patients to have their plan established or reviewed in the last 18 months, so they can retain access to allied health and other services. My advice to you all on this is to go back and start to review, if you haven't reviewed their plans, to keep them in the 18-month timeline so they can continue to receive the benefits in that 18-month period. Referral process is going to be easy. It's going to be via normal referral, as what your doctors make now. So no EPC referral, and the patients do not lose access over that period of time. So let's look at what are the goals. There are certain goals on this, but the one I want to flag with you is encourage the regular review of chronic condition management plans. Look, this is just me thinking out loud on this. My health record is being updated. We know government have turned around and said they want a shared care plan that everyone can input into the multidisciplinary care plan. I'm just reading between the lines on this. I think there's going to be a standard plan and we're going to have to upload it to My Health Record. And then everyone will have access to allied health, and everyone will have access to that particular plan as well. So it becomes a true multidisciplinary plan that other people can gain access to. You would have seen this. These are the item numbers that have already been out there for MyMedicare, some 1st of July 26, but there's no dollar values on this. But isn't it interesting? Look at 92029 and 92030. Develop a chronic condition management plan via telehealth. So that's an interesting one. And different item numbers for the prescribed medical practitioner versus and the GP item number. So it's interesting that telehealth looks like it's going to play a part in these chronic condition management plans. So what I want you to start to think about, there's some things that I want you to start to think about. Just takeaway messages. I'm just about to finish my slides. So takeaway messages. Ensure your practice is registered through PODA by MyMedicare. Have the discussion with the practice team on what MyMedicare system is and what it is not. Look at what workflows change may be needed to amend to suit the patient registration process. Target patients who are currently in your chronic disease management program now for the registration. Why are we targeting every patient who walks through the door? Why aren't we just targeting cohorts of patients? I'm only charging cohort of patients who are my chronic disease patients. We don't do level CD telehealth, so it's not an issue at our point in time. So we're putting our resources into chronic disease patients. Make sure you got MyMedicare posters. Make sure you get links on your website for videos from Services Australia you can refer to patients. And post information on your MyMedicare on your Facebook site or your social media sites. Now, I know full well it is very difficult to convince because everyone say, whiff on what's in it for me. Start to think about your chronic disease cohort because there could be something in it for them. But most of all, this is a takeaway slide, but most of all, clean up your data. Have an efficient recall system in place with tools to manage billing reviews, because this is going to be the basis by which you're going to manage and bill effectively accordingly. There's a thing called TVM, time value of money, and it's going to be really important because there's going to be key review times within the plan period. And if you push those plan times out and not being able to claim the value for that review when they are due, you're going to be pushed out and the cycle's going to be pushed out. So it's called TVM, time value of money. Think about this. So, for example, if the review is to be done at 4 months, but the person who does the review at 4 months is on holidays, it's not going to be done for 6 months because they've got to get back and all of a sudden you've got 2 months being pushed out for the value of that review. Time value of money, data, recall system is most important. I'm not going to go too much to the aged care side, but GPACI, because it's a very complicated system, but there's some overarching components of this. You will know that there are increased funding for general practice visits to aged care residents, and there's what does that look like? There is some eligibility requirements around this, and you know what those eligibility requirements are. I don't need to tell you more than that. There's some exemptions in relation to patient eligibility. I know the challenge. There are the systems, and I can't take any questions on this in relation to the challenges around the recording of patients in MyMedicare in GPACI, because it's a systems issue, and I can't answer questions around the design. Government puts systems out there. They wait for people to tell them where the issues may be, and then we'll adjust it accordingly. But there's some exemptions from there. But I think there's a patient monitoring and tracking tool available there. I don't know if anyone uses it, but that's a really good tool for reviews and tracking patients when they are due, and the payment mechanism for billing cycles, etc. That's a really good document there. And there's some guidelines there around aged care incentives. What we don't know in relation to the whole framework at present We don't know the new fee structure for chronic condition management plan. I think there will be a standard plan template. I think it may be required to be uploaded to My Health Records. We spoke about what we don't know is about the future incentive program and what the percentage split between incentives and MBS. We know it's a 60-40 split. We don't know the finer details of the frequent flyer program at this point in time, and we spoke about what that looks like. But the big thing in my final comment really is around, and we've spoken to government around this. We've put it to government every presentation we've done to government. The minister is fully cognizant of this. The department is fully cognizant about this. And this is a colleague of mine made this comment publicly. We need a funding model that is patient-centred, fairer, supports ongoing relationships, and is flexible enough to support multidisciplinary care and protection. Do not, please, give us all these changes without an infrastructure and incentive program to make it work. Well, there you are. Thank you very, very much for that. Tricia, over to you. Are we going to go through some?
Yep.
We've
got a couple of questions here, Gary, and I've got one. So, you know, got to answer my questions. So I've got a question from Pam, and it's really a request for your opinion, really. What does patient-centred care really mean in terms of primary care, in your opinion?
Oh, well, patient-centred care is really about every service we provide is about the patient. This is why I spoke about health literacy and health equity, Pam and Tricia before, because we actually have to be, the patient has to be involved in the delivery of their care. They have to take the lead on this. And that's why health equity, health literacy is so important. Do they have the ability to understand what it's all about? Systems literacy. What does that medication mean? How do I gain access to? What are you going to do about this? I'll just give you an example. And it's not a sexist statement, but I was talking to one of my nurses the other day, one of my chronic disease nurses, and they used the psychology around obesity in this particular patient. What's your driver? Oh, really, my driver is this patient says my daughter's getting married and I've got my bride's mother's dress to get into. So there became the lever for her to start to lose weight. So where are the drivers? And patient-centered care is about involving them in the delivery of their health with the support of who else may be around, and of which the doctor will be one.
Okay, thank you very much for that, Gary. So now there's another couple of questions, but they're a bit specific, but I'll ask them.
Yeah.
And I might put my 2 cents worth in, not
Please
this
do.
particular one. What will happen if clients move their MyMedicare registration to a different GP clinic? Will the allied health referral still be in place? My thoughts are that this is some of the detail we don't know yet. Yep. So
look, I think they will stay in place, yes, because remember, there's about patient-centered care. We're moving the care not from the clinician; it's about the patient. Okay. So, and that's one of the reasons why, Tricia, that the government are looking at what does MyMedicare look like. Do you follow? And the My Health Record looks like. And this documentation will take place. So the patient has the ability, it's voluntary patient registration, they can change practices, they can change registrations. So yes, I'm with you, Tricia. I don't know the finer details, but I would say the answer would be yes.
We would certainly hope so, wouldn't we?
Because Tricia, we know full well now that the name that I put, not me, the name a doctor puts on a referral pathology means nothing. The patient can do it. The referral to a specialist, they can be unnamed, you follow? And they can go anywhere. So the referral is the referral. Who it ends up with is up to the individual.
Yeah. Okay, fantastic. Thank you for that. The next one, as I said, is also, it's about, given MyMedicare registration can be overridden without an alert to patients or practices, although I suspect that patients have to do something about being overridden. How are clinics expected to track patients who deregister or who are registered with another clinic. We can certainly look into that a little bit further and provide some information after the webinar. But if you've got any insights, Gary, that'd be great.
The only insight that I've got is that you have the ability to go on to Proda and see those transactions. It doesn't seem to be a push-pull transaction at present to practices. Dare I say it, part of the ICT software updates, I actually think it's going to be integrated into our software as alerts in the patient's demographics, etc. So I think it'll be hooked up through the IHI process eventually on that.
Okay.
But there's nothing, all I can do is go into Proda, look at the MyMedicare registration and look at the transactions in there.
Yeah, I mean, I suppose we all know that the complexity of that is how many patients have you got? You know, the numbers of your patients make that quite tricky. But there were a couple of webinars that the department did in the last few weeks, and they did address some issues around this. And so I think that we might put those links also in the information, so the webinar links in the information that we send out, so that practices can have a look at those if they weren't able to attend those webinars.
Tricia, I must admit, some of those webinars and some of those online videos now are getting very, very good. The early days they were very scratchy, but now they're very easy to follow. Even I can follow them.
I think they're starting to respond to the feedback, which is great.
Yeah,
I think that's really good. It's about time, but it's great.
Right.
So I've got another question about chronic disease management plans or chronic condition management. From the 1st of November, can we still charge 721 if patients aren't registered?
Yes.
Basically, all the changes have been delayed to the 1st of July. Is that correct, Gary?
That is correct, Jess. Now, I'm going to say to you, it's really important that come prior to July 25, that you've gone back and done your reviews within the system. Do you follow? So come July 25, those people have still 18 months left under the old system before they go into the new system. Because what government does not want, they don't want people to lose their benefits as at July 1, 25. Do you follow? So there's an 18-month transition process. But get in and start to do those reviews now to keep them current under the current system, yes. And
to identify your patients who are under chronic disease management plans so that you can register them, because all of the general practices do amazing jobs with their chronic disease management plans, and they deserve the payment for that work.
Right.
You really don't want other practices getting the payment and you still doing the work, because you know that that's what happens basically. I've just got another one. Will the allied health visit allocated number change? So we're talking about the 5 visits per year. We don't know that, no.
We don't know.
It'd be nice if it increased.
Yeah, go back to the 10 years. Yeah.
Yes.
The government knows that. They've had a lot of government have had a lot of representation, especially from the Allied Health Council, the ARPA and all those. So government's fully cognizant of the feedback around that.
Yeah, thank you. I'm going to ask you a very quick, well, maybe it's not so quick, so you tell me if it's not. But it's one that general practices have been asking us consistently about the change to chronic condition management, basically. And it's about the fact that the department has said that they're going to equalise the payments between reviews and the actual plans. What happens to the funding that came with the team care arrangements?
As you know, TCAs are going to disappear.
Yes. So is the funding going to be spread across the other 2 items?
The TCA will roll into the plan upfront. The TCA will become the referral letter. The government have said, and they've said all the way along, back in 2019 as well, when I was on the MBS Task Force Review, it's actually in the 10-year plan, it's in the Strengthening Medicare Task Force Review. The Minister has made public statements, and I can't say that I've seen the dollar values at this point in time, but the total program in relation to the plan, TCAs and reviews, the total dollar generation is actually going to be rolled into the total payment of the new system. Now, in saying that, one of the things you've got to be mindful of on this, we raised this in 2019. Our concern was a business model where some organisations got in, did a plan up front, patients didn't know about it, they charged 150, whatever the value was, and never saw the patient again. And when the practice went to do the plan themselves, where the patient was, they couldn't do it because the patient was unaware they had it done somewhere else. So our recommendation back in 2019 was to look at how is there a disincentive for that to happen. And partly this incentive is don't expect the full payment up front. There will be, I believe, there will be a discounted payment up front of $1 value. It won't be the, whatever it is, 150, whatever the dollar value is for a GPMP. That won't happen. It'll be a lesser amount. But the drop down of that lesser amount will then fall into the harmonising of the reviews and the drop in the value over the balance of the plan. You'll still receive the same amount. But what this will do, though, Tricia, it will hopefully stop the business model up front by some practices, and then put it into a quality agenda that the practices to obtain the balance of the funds over that period of time that they do the work.
Absolutely, Gary. Actually, I think that's a fantastic way of putting it for practices, because as an ex-practice manager myself, I've had it happen to me on many occasions. I've also worked in Aboriginal health, happened all the time. So I think that really is an incentive for practices to actually register their patients and make sure that they're the ones actually getting the dollar value. And I hadn't even thought of that perspective, the fact that there's less upfront, so there's less advantage to just doing those opportunistic plans.
But that's why, Tricia, I say to everyone on here tonight, and I say to practice managers Australia-wide, is get your recalls and reminders, recall systems effectively working, because it's going to be about when do I do that recall, when do I do that review, and then I can claim a review when I do the review. So you want that longitudinal quality of care delivered over a 12-month period, you follow? Whatever they to get the full benefit. But if you miss one of those reviews and push it out by 2 months, you're not going to complete that review, complete the program for 12 months plus 2 months, do you follow?
Yep.
The time value of money concept is a really important thing. So I want everyone to Google time value of money, TVM, and see what it means to your cash flow and financial stability of practice.
Thank you for that, Gary. We do have one more question, but it's actually about change management.
We'll get to.
Yeah, so I'm going to leave that.
I'll leave that to Riley.
Yeah, Riley is next. And Riley, I'd just like to welcome you if you'd like to start your presentation now.
Thank you so very much. And thank you, Gary, for a equally interesting and terrifying presentation for what we've got coming up. Hopefully everyone can see that nice and clearly once it loads. There we go. All right. So I'm going to be taking us down the hefty road of change management, which sometimes sounds like a buzzword, but trust me, it is an art, and there absolutely is an art to it and something that we can learn. So I want to start off with a really good but very strange metaphor I heard recently around change management. I'm sure you all know about the transformation that we go through from a caterpillar to a butterfly. And we also know that change doesn't simply mean the caterpillar is growing wings on its tiny caterpillar body and then becoming a butterfly. What actually happens for the caterpillar to undertake that change is that it cocoons itself, and then it undertakes what I think is the world's most miraculous process. It literally becomes goo. It liquefies entirely. There is no solid pieces within it. It liquefies entirely. The caterpillar breaks down completely into a fluid mass and somehow retains the most valuable components of itself, such as its memories and its instincts, before reforming into a completely new creature. We still have no idea how that happens, but it is able to retain those memories and instincts and everything and come out the other side. So the way this relates to change is that sometimes when we're forced to or choose to make really, really big changes within our work, things might feel like a big soupy mess for a certain period of time. But if we can identify the most valuable parts of our practice and embark on changes with a plan and a clear understanding of what we want it to look like on the other side and how we want to retain those important pieces, it's less like soup and it's sort of more like fluidity and flexibility. So the caterpillar breaking down into goo before reforming might look inefficient or dangerous or chaotic from the outside, but inside it's going exactly as planned. So when things feel like they're getting a bit chaotic or a bit unclear or a bit soupy, remember that fluidity is part of the process. And right now you're just in the goo stage before things become clear and solid again. So when it's a bit uncomfortable, just remind your team, we're all just in the goo stage. We're all just goo. So I'm sure everyone at some point in their life has heard Heraclitus's wonderful saying that the only constant we can rely on in life is change and death and taxes. And this can't be more true than in the primary care landscape, especially over the last 5 years. And as Gary has forebodingly forewarned, especially over the next 10 that we're looking down the barrel of. So because of this, it's really imperative that we're able to not only face change, but embrace it when it presents itself. So moreover, we have to expand on the mindset of how we embrace or how we approach change, and then also lead our teams to do the same. If not with positivity and excitement, then at least with a begrudging willingness and acceptance that change has to happen. Personal anecdote, at my local bar on Sunday afternoon, I was accidentally served a limoncello spritz instead of an Aperol spritz, which is very uncomfortable for me because I don't like change in my personal life. But had I not embraced that change and drunk the drink instead of sending it back, I would never have realized what a beautiful thing a limoncello spritz is. And now I have 2 favorite drinks. So embracing change oftentimes can lead to positivity. So obviously, change management and having a really, really strong change management mindset in your practice has a few benefits. That's increased employee engagement and team morale is a huge one because the burnout and the stress that can be caused by change management is a huge, huge impact on any team. Reduce resistance to change, which gives you more opportunities for improvement in the future. And improve chances of success for any newly implemented activities. About 80% of new changes fail in the first 12 months because they aren't implemented correctly or because there is a resistance to them and they're not fully implemented by the team. So there's 5 pillars of change management, and we're going to touch on all of them. I've written myself some notes through Gary's presentation because I saw some really, really great examples of each of them within that. So excuse me if I'm looking left and right. So our 5 pillars are leadership alignment, stakeholder engagement, communication, mindset, and training. I have 2 favorites in that I will get to, and I will explain why. But obviously, in some, we can't all be perfect at everything. There are going to be some teams that are really strong in 1 or 2 areas and might be a little bit weaker in others, or there's going to be certain changes that require less of one and much more of another. And so that's a matter of playing it by ear, but for the most part, this is what we need to be able to implement change really effectively. So I'm going to start with leadership alignment. This one is pretty much just like start at the top and move from there. And what this means is that everybody that is leading this change is on the same page and is showing a united front. That is the biggest thing. If you're a parent and you're co-parenting with another parent, you might know how this feels. As long as you've agreed on something, you both have to stick to it and show the united front so that there is no cracks and there is no questioning and that everyone knows that you're supporting each other. And to do that, you need to be able to collaborate between your leaders. Depending on the size of your practice, you might have just one practice manager who's also a practice owner. You might have a practice manager, a couple of practice owners, maybe some practice partners, maybe a GP principal. You might have a senior nurse. Depending on the size, and especially if you're an AMS or if you're a corporate, you might have senior management, executive teams, etc. Depending on the size, your leadership team is going to look different. But what's most important is that changes, when they're decided, are collaborative, and the initiative's decided amongst everyone, and you come to an agreement. Even if everyone's not agreed in the conversation, that you come to an agreement moving forward. Really effective way to do that and to make sure that those changes are aligned is that you are all really clear on your shared vision for your practice and the goals that you want your practice to achieve. If you've got one GP principal who's looking to retire in 4 years, and one practice manager who's looking to grow the practice by 3 more doctors and increase services in the next 5 years, the two of you haven't got shared vision and goals for what's going on, and what you're going to want to implement is going to be different. So it's important to make sure everyone's on the same page at that foundational level before you start implementing change. And lastly, leaders need to at least see the value and the purpose of a change in order to support it. They do not necessarily have to like it. Change is hard, change hurts. Sometimes change happens outside of our prerogative. For instance, the government changes that are coming. MyMedicare, that was probably no one's choice proactively. It's obviously got a lot of value and a lot of merit. And if we understand that value effectively, like for instance, if we understand the value over volume, and we understand how to leverage that 60-40 split of your incentives versus your MBS, you will get value from this, and you will be able to create tangible outcomes and improvements for your organization. So if you understand the value or the purpose of the change, that is enough to push it. You do not have to like it. Very important. So the importance of backing each other up. It's really, really important that you obviously build trust within the leadership team, but also within your team, because if you, and enhance your consistency in messaging. As long as everybody's saying the same message, you've got that united front. If cracks start to appear, that is when employees will start to split off into different tracks or different cohorts, and it will may become an us against them. When they see someone that might have an empathetic sort of understanding or be against the change necessarily that they and the employee feels the same, that is where you can start to breed resentment and bitterness in a change. So it's really, really important that leaders have that united front and the cracks don't start to show. So some healthy approaches to change for leaders is obviously open communication, but we'll come to this in a lot more detail soon. Empathy and support, again, which we will come to, but understanding those concerns and providing reassurance. Under no circumstances is change always rosy, even if it is a proactive change that you've chosen to go through yourselves for all of the benefits. It doesn't mean it's going to be easy. So being fully understanding and empathetic about those concerns, and also celebrating wins. I'm going to touch base on this point quite a couple of times. But acknowledging progress will help to motivate teams, and it will help to put people in the mindset that the change is a positive thing, or that you're at least getting somewhere, as opposed to it being another piece of administrative burden on your plate. So having aligned leaders also has a great side benefit, which is a positive impact on the practice culture. So it's that collaboration resilience that we're looking for that comes from change management, but it also encourages innovation and adaptability among employees, which is really, really important because it can identify champions within your team who may have otherwise not had an opportunity to shine. You might have a receptionist who's actually an absolute whiz at data extraction or software or hot doc or supply management that just hasn't had that opportunity before, and she might just shine and run with it and go with it, and she's able to expand her respect within the practice. She's able to expand her role. She's able to make sure that she's got these different things that's going on, and that can also mean that you as a practice manager or as a leader can start to support others and delegate roles out and take the burden off yourself, and create individuals who are champions in the practice of certain changes or certain new implementations. It also reduces resistance to change through that visible leadership commitment. You know, everyone's on board, you're going to be on board too. So a few tips, regular alignment meetings between the leaders to make sure everyone's on the same page. This is especially true if it's a moving beast, like a lot of government implementation is and can be sometimes. We start to find things out piecemeal. If someone learns something, it's important that all the leaders know that thing at the same time, and it's important to agree on what the messaging is around that. A documented change management plan or milestones is really, really helpful. It doesn't have to be super formal. It doesn't have to be a big, huge procedural document that you're going to put forward at accreditation if you don't want to. Simple milestones with dates on them or with achievement blocks is totally acceptable, and it will break that huge piece of meat that you've bitten off to chew down into smaller chunks that are sizable, manageable bites. Transparent decision-making processes. That's not just to your staff and to your stakeholders, but also internally between leaders, why they are taking a stance on something, why I'm a yes, why I'm a no, why I'm concerned, why I'm not. That actually puts the onus and accountability back on the person as well to say, are you changing for change's sake, or is there actually a benefit here that's going to outweigh the effort we're going to undertake? Or are you digging your heels in because you're just feeling a bit stubborn, or you're just a bit tired or exhausted? And putting that accountability back on people and making them reflect why they've taken their stance can be quite impactful as well. And continuous feedback loops with stakeholders to adapt strategies as needed. I will come back to this one. Okay. Second pillar, stakeholder engagement. So this one is super important, but it also requires a bit of creative thinking. Engaging people who are impacted in a change obviously is going to ensure smoother transition. We are seeing this with MyMedicare right now. Patients have not been taken on this journey. As much as we can lead a horse to water, we cannot make them drink. I'm a health literate person, and as a patient, I was sent a text message that said, sign up for MyMedicare. Here's the form. And I, as a person in the industry who had an inkling of what MyMedicare was through, through my sources earlier, still had to go on it sometime to find information on Services Australia. And I still struggled to find a format that suited my needs for the communication. I wanted like a fact sheet with dot points. There was a video, which is great, but I don't do video content. There was a big, huge form, which is great, but I have commitment issues when it comes to reading anything longer than a page. So even as a health literate person, I struggled to find a communication method in a format that suited my needs for that particular journey. And my practice that I go to as a patient, outstanding practice, definitely dropped the ball around communication about what MyMedicare is. So engaging those impacted obviously is going to ensure that that transition happens more smoothly. It increases the acceptance and reduces the resistance to change. If someone doesn't understand why something has happened, they're not going to buy in. Case in point, all of our current patients that haven't signed up to MyMedicare. It also identifies, and this is probably the most important point, it identifies those boots on the ground challenges before you have to learn the hard way. If your receptionist knows that at 8 a.m. Beryl comes in for her INR and she always wants to have a 5-minute chat beforehand, and she needs to get the fax paper ready for this doctor, and she needs to get the hot doc thing ready for this doctor, and she needs to get this faxed out, 8:05 a.m. to 8:10 a.m. are her busiest 5 minutes of her day. And you've said, I've implemented this great new process and you need to undertake this particular thing at 8:05 a.m. It may seem like nothing to you, but to that receptionist, that is going to interrupt her entire day. So understanding those boots on the ground issues before they happen, one, is going to alleviate a lot of frustrations. And two, is obviously going to really improve that implementation and give people a better mindset. People are willing to accept a mistake or a teething issue once or twice. 3 times is the magic number that suddenly flicks the confirmation bias in their head to open-minded, this is okay, everything's going all right. Obviously, a couple of teething issues, to all of a sudden, oh my gosh, the entire thing was a mess. It was chaos. Nothing was done right. 3 is the magic number. When you have 3 examples of something, that turns into everything. Everything was a mess. And after that switch happens in your brain, you will look for every single time something messes up, and you will forget every time that something goes right. So you want to try and minimize those initial teething issues as much as you can before they occur. And that is where stakeholder engagement is so valuable. People are also very willing to tell you how it's going to go wrong and how it's going to negatively impact them and how it's going to change things, which is great because that's where the teething issues come out. Less likely to tell you how wonderful it's going to make their lives. So when you're identifying key stakeholders, you need to think outside the box, you need to think creatively, and you need to think about every single person that gets touched by this process from start to finish. Patients, is there going to be a notable change to their service delivery experience? Do they now have to book online as opposed to calling up? Are they going to have longer or shorter appointments? What happens there? Do they need information like on MyMedicare? Staff, how is this going to impact workflows and what roles are going to be impacted? Is it going to improve workflows in the long run, but have a really, really difficult time for about 2 weeks while people learn it? Is it going to add administrative burden to someone who can't otherwise take it? Which roles are going to be impacted? Don't just think about the person who's doing the service delivery. Think about the person who has to write the policy or process the accounts or go back and back and back and see who also might be impacted here. Suppliers and contractors. Is there a way, is there a change to the way that we attain our tools or our expertise? Do we need to bring someone in? Do we have the capacity internally to undertake this change, or are we going to need to bring in an external contractor to give us that expertise? Are we producing or providing a new service that requires new consumables or new equipment? Are we going to need to find a new supplier? How is that going to work? How often are we going to need to supply? These are all worth considering, because if you're going out on a new branch, how do you know that that supplier is impactful or is right for you? How do you know that that contractor is legitimate, is going to give you the expertise? The community, is this going to impact the greater community around us? Are we offering a service that wasn't there before? Are we consolidating and taking away a service that is being relied on? Are we partnering with a community service or something like that, a group outside our usual catchment that might have different ethnicities, different cultural groups? Do we need to adapt our service offerings or the way that we speak with our patients to make sure that we're meeting those needs? Do we need education on that? And governments and funders, are there stakeholders in this change who have their own wants and needs relating to the change that we must fulfill? For instance, if you get a grant, there are some certain KPIs that you need to meet. We'll give you this money, but you have to do this for us. You might be able to do these other things, but this is what we need out of this. Have to identify what are the non-negotiables and what are those governments and funders looking for. So some strategies. Open communication, obviously. Regular updates through meetings, emails, newsletters, whatever it is, with the stakeholder in a format that suits the needs of the audience. So in a format that suits the needs of the audience. This is so important to me as a communications background. If you know that your supplier or contractor answers emails to you, shoot them an email. But that's not going to work for all of your patients. You can't email all of your patients with this because that's just not the way that you communicate with them. Are they going to read an SMS that's short? Are they going to look at a poster? These are sort of the things that you need to think about when you are making sure that you're getting the information to them, because your intent is to educate your audience as best you possibly can. And if you write down a huge amount of paper and send it out, but no one reads it, you did not meet your intent. Feedback mechanisms, so surveys, focus groups, informal chats, suggestion boxes, etc. This can happen before and after a change, and both are equally important. If your change is going to impact people, it's so important to see what they think about beforehand. This is obviously much easier with staff, suppliers, partners, those kinds of stakeholders, but it's still really valuable with patients if you can. Maybe you've got a few choice patients that you chat to informally as opposed to doing a big formal survey. And then post-change. Once you've implemented a change, it's so important to see how it's going and to see where you can fix, what you can improve, etc., and have that rolling improvement. Involving people in decision-making. If the decision affects them, nothing about us without us. Try very hard where possible and within reason, obviously. to engage stakeholders in planning and implementation and decision making. Define your expectations. So clearly identify and plan for mandatory outcomes defined by the practice and other stakeholders. What does the government want out of this? What do we have to do? What are the rules to MyMedicare, to the new claims, to GPACI? What are our rules? What do we have to do? And what do we want? So MyMedicare, this is what we have to do. We want 40% incentives. And these are our musts and our mandatory outcomes. We're going to put them together, and that is what we want from this change. And then adaptability. Chances are with changes, it's often because it's brand new to everyone, unless you're very lucky and you've gone through a change in a different practice or something like that, that you can apply learnings to. Be adaptable, because the chances are everyone going through the change is going through it for the first time together. So you don't know. You don't know what's perfect. You don't know the right way to do it necessarily. You don't know the exact method. So adapt when you need to. Your plan is not set in stone. Be fluid, be flexible, be gooey. All right, communication. As I alluded to, this is my favorite because I do have a communication background. It was a expensive waste of 4 years at university, and they cancelled the degree after I finished because it doesn't give you jobs. But it gives you a very, very important skill set. And that is being able to communicate with everyone in a format that suits their needs. So it's obviously crucial for clarity, and it mitigates that uncertainty and anxiety. Uncertainty and anxiety, people don't like feeling on edge or unbalanced. That is where resistance and bitterness comes from. It stems from uncertainty and it stems from anxiety. If you can mitigate that, you will avoid the resentment and you will have a better chance of having a positive mindset. It also defines the why. Change doesn't happen because it's fun. Change happens because it has to, or because it needs to, or because you want it to. It doesn't happen for fun. There is never change for change's sake, or there should never be change for change's sake. If it has to, maybe a legislation change, maybe a standard changed, maybe the government implemented something new, maybe an MBS item changed, had to happen. That's the answer. It had to happen. There's lots of benefits, and here I can explain them, and here's the why for the government. But why are we doing it? Because we have to. Why are we changing from paper records to electronic records only, or hybrid to electronic only? Because we need to in order to stay relevant. Or why are we getting hot doc recalls put in place? Because we want to, because we want to provide better care to our patients. Why are we introducing smoking cessation clinics? Because we want to. If you can understand the why, you are much more willing to get on board. So transparent messaging, clearly articulating the reasons for the change, your expected outcomes. So that's going back to our mandatory outcomes from our invested stakeholders and the mandatory outcomes from our leaders, and how it is going to affect the team members, and try to be as honest as you can. And also be really, really clear, like Gary was in his presentation, on what you don't know. That is equally as important as saying what you do know, because it is going to head off. It's going to make sure everyone feels like they are fully informed, that nothing is being kept from them, and they know where the limitations of your knowledge lie. Regular updates. These can be scheduled meetings, they can be progress reports, they can be emails, they can be a communication book. You might have a big whiteboard in your staff room. It doesn't have to be super formal. It can be quick. But making sure that people feel like they are kept in the loop, even if there's nothing to report, but you thought there would be by now. Say there's been like 2 weeks, no one's heard anything. It's always great to just be like, hey guys, just letting you know, we're still waiting on feedback from X, Y, and Z. Encourage feedback. So create opportunities for team members to voice concerns and suggestions. Interestingly enough, and I'm sure that you've all got a patient or two in mind that breaks this rule, but people aren't usually likely to share feedback or suggestions with you if they aren't asked, because they don't know if it's warranted. They don't know if there is an ability to give feedback, or if there's an option for things to change, or if there is flexibility, or they don't know that their opinion is valued at all. But if you put forward and ask for feedback from these stakeholders, from your suppliers, from your staff, from your community, from your patients, and they put something forward, chances are you will find some really valuable information in there. And active listening, this goes back to the point that I was making before. Demonstrate that you value input and be open to feedback, because remember, it is oftentimes the first time everyone is going through this change together. So no one is a guru. Everyone can learn from everyone. Consistency is key. Ensure messages are aligned to all levels of leadership to avoid confusion. If you're going to use acronyms, make sure everyone understands what the acronym stands for, or have it somewhere. Communicate that really early, and remember to continue to communicate it in case people come into the changes partway through. If something has a name, like MyMedicare, call it MyMedicare and make sure everyone calls it MyMedicare. Don't have someone calling it the Medicare change, or someone calling it the new My Health Record thingy, or someone calling it the voluntary patient registration thingy, because people might start to think that those are all different things. So consistency in messaging is really, really important to avoid unnecessary confusion. And try to keep your promises. This is so important as someone who's been in this, on the other side of this, as a junior staff member in the past. If you set a timeline for something, try your hardest to stick to it. If you cannot stick to it, be clear about why you cannot stick to it. The only thing that is worse than going through the throes of a really big change in an organization is living in limbo. If you say that they're going to have an answer on something by Friday, and it gets to Friday and they have nothing, and then they go home Friday afternoon, and then they have to think about it all weekend, and they think, we'll get in Monday and they'll tell us first thing Monday, and Monday passes. Every single one of those hours feels confusing and stressful and creates resentment and bitterness. If you don't know, say it up front and say, I don't know. You're not going to have the information by Friday. I'm going to aim for next Tuesday. If anything changes, I am going to let you know before then. So just being really open and honest about what you can and can't do is so important in changes, and it builds that trust and it builds the rapport in the team that you need to encourage. Provide the tools, resources, and information necessary for staff to adapt and to succeed. You want them to win. You're all in this together. You want them to win. So if it is a template, if it's work instructions, if it's online modules, if it is time to undertake training or to go and attend something, try and give them everything that you can possibly give your team to actually implement this process long term. If something is easier but less efficient, the old thing was easier but less efficient, they will still go back to doing that in a really busy period or in a really stressful period, because it is what your brain is comfortable with. Even if you know the other way is more efficient, you will go back to what you know if you don't have the tools, because it is safer, and you know you're not going to make a mistake. So try and make it idiot proof. Try and give templates. Try and give anything that you can, flow charts, stuck to the screen, anything that you can to make the change as seamless as possible so that people want to try and undertake it. Acknowledge and celebrate team achievements to reinforce that progress, that chipping away progress, and improve the positive mindset around the change. And a big one of that is celebrate. When you're done, celebrate. Go and do a team building activity. Go and have after work drinks. Go and have a dinner, have a team lunch. Do something to say, we did it. We did it, and we did it together. Gather feedback on communication clarity. So this is taking a step back from just the feedback we were talking about. Actually ask about the communication that they're getting and the effectiveness that that is having, to see if you need to give more information or less. Are you overwhelming them with too much information? Have you been clear? Have you given them the communication tools they need to understand? And adjust your strategies. I'm going back to this and back to this. Adjust, adjust, adjust. Be flexible, be gooey, be fluid. Training. So obviously, training is entirely essential for equipping employees with the skills and knowledge to adapt. This is also a really soft skill, to be truly honest. Adaptability, resilience, stress management all sort of go hand in hand when it comes to improving your own internal soft skills. And that creates a really good foundation for being open to change. But obviously, training also supports those smooth transitions, and it minimizes disruption as best we can. So this is probably really important when, if we hark back to Gary's presentation on the foreboding warnings of the ICT changes that are coming. Technology is hard, and I say that as a millennial learning. I can't use the Samsung phone. You put that in front of me, there's nothing I can do. I cannot open messages, nothing, because it doesn't look the same, doesn't feel the same. It's hard, and it's a real learning curve, and it's not a learning curve that you want to spend doing when you have a day job, when you're supposed to be seeing patients, supposed to be managing a team, supposed to be answering phones. You don't want to sit there and learn a new software or anything like that. But if you keep that end in sight, and the fact that it will create more efficiencies, that is going to be why you get through. And the training that comes with that is the most important part. If you are educated in how to use it, you will use it. So training teams in new changes, even if it only sort of impacts their role a little bit, it's really, really good to give as much information as you possibly can within reason, because you create teams that can adjust quickly to roles and responsibilities. And this is excellent for creating collaborative and comprehensive care and continuity of your practice services. If something goes wrong, obviously we've had lots of staff retention issues across the board and difficulty with recruitment and things. If you need a nurse to work the front desk or the practice manager to take on a different role here or there, you've got that cross-pollination and people are across it all. So training programs are wonderful, but they need to be responsive to the needs of the team. We go back to person-centered care, which really genuinely needs a mindset change in and of itself to understand and to embrace. We need person-centered training. So team-centered training. What does your team have the capacity and the capability to do? Every team is different. Every single team has different levels of education, different preferences to how they learn, and different capacity in terms of what spare time they actually have. So what we need to do is we need to identify what we're missing. What skills gaps are we missing? Who's interested in taking those skills gaps on? And this is where those champions can come back into it. And then tailored training wherever possible. If you can, if you have the capacity and capability, designing programs specifically for your team is amazing. But also, you can draw on lots of existing resources, especially for things like government initiatives. There are online modules, there are resources, there are toolkits, there are fact sheets that you can draw on. And try to be creative with the way that you pull training. Some team members, especially, I'm not being ageist here, but I know that my grandmother particularly likes it when I sit next to her when I'm showing her new software. And so there might be some team members that really need to just see you do it or get you to show them. And an online module is going to do nothing for them. And it's a matter of knowing your team as a leader and understanding people's different learning modes to be able to cater to that. They'll be fine with an online module. This person actually needs me to sit with them. But you need to make sure that the barriers to access to learning are removed. If you give someone a 1 hour online module, but you don't give them 1 hour to do it, they will either not do it, or they'll do it piecemeal between patients a minute at a time, or they will run it in the background and not listen, and then give you the certificate at the end. None of those met your intent. Your intent was to educate your team member. You gave them the tools, but none of that met your intent. So you need to make sure the implementation is as effective and those barriers to access are minimized. Pre-change training and post-change training are both important. So preparing people in advance before a big change happens, making sure they have all the education they can based on what you know. Again, obviously, you've got limitations to what you do and don't know, and you need to be clear about them, like we've just done in Gary's presentation. Pre-change training, change happens. Post-change training. All right, this is what we've learned from the change. This is the information we've got. Here's what's not working. Let's fix it. And ongoing support. So these might be things like flowcharts, work instructions, refresher courses, resources to go back to, things that people can draw on to remind themselves, acronym sheets even, keywords, glossaries, things like that, things people can go back to rely on so they don't have to go searching and they feel confident. Also really important to evaluate the effectiveness of any training that you put in to make sure that it's actually meeting the needs of your team. All right, last one, and I'm going to whiz through it. Positive mindset. So this is the belief that change can lead to growth and improvement. The belief that missing out on Aperol spritz will bring you an even better drink. Openness to new ideas and willingness to adapt. So it's going to bring the team enhanced resilience, the ability to bounce back from setbacks and not get stuck in that confirmation bias, negativity mindset I was talking about earlier. It's going to increase engagement with the team and give a bit more team morale if people are all working towards the same goal. And it's more likely to implement your long-term change and not let you fail within the first 12 months, actually make those changes move forward. If you keep the end in sight, clearly articulate the why. Why are we doing this? Why are we doing this? Why are we doing this? And you use those visual reminders like charts or posters or checklists or dashboards, whatever's going to work for you to celebrate milestones and to like tick stuff off. That is just the most satisfying thing when you're working through change. So to cultivate positivity in your team, open dialogue is really important. Change is really hard, and there are really constructive ways to vent frustrations. It is not always just a bitch session that just makes people feel more and more and more negative. It is something that can release frustration and then learn from, especially if one person voices it and then multiple people go, yes, that is happening to me as well. You can see a common thread of an issue and you can go in and fix it. Also, we can recognize people's contributions, work on our mindfulness and stress management, and positively reinforce and model that positive behavior. If all else fails, we can unite against a common enemy and say, let's just get this done and rip this Band-Aid off and get through it. Trisha, do I have time to quickly run through the case study or not?
Yeah, I think that'd be really useful. Thanks.
Okay, I'll whiz through it. I'm so sorry I've gone over, guys. So I've got two practices. I've got Willow Creek Medical and I've got Greenfield Medical Practice. Both practice managers at these practices have decided to implement new software. They're using some really subpar medical record software. Both of them have decided that they're going to go into a new software. I'm going to take you through what Willow Creek did first. So at Willow Creek, the practice manager just found something. It seemed to be the market leader. It looked pretty good. It had what she needed. And so she announced the change that it was happening to the team without really adequately explaining the reasons or benefits, which kind of led to confusion in staff. They're like, ours is fine. What's wrong with it? It's a bit clunky, but why are we changing now? Is there something that's prompted this? She then really struggled with the training. People didn't have time to undertake it, and it was a huge set of training sessions. So she actually went through the training herself with the provider and then tried to give that training verbatim to her team, which resulted in a lot of Chinese whispers. There was a few things that she didn't fully understand herself and didn't come with any written communications. So everyone got some different advice, and everyone was trying hard to help each other but confusing each other more. This meant that there was a lot of resistance to change. Many staff were resistant because they just really didn't understand. It scared them, and it was creating a lot of delays. And there was absolutely no feedback loop whatsoever. So not from the staff and not from the patients. So they had this amazing piece of equipment, but didn't know how to use it. Like my dad buying a new phone every single year, but all he does is texts and calls. Lots of great features, no ability to use them, which results in a giant waste of money. So what happened at Willow Creek was that unfortunately the implementation was incredibly chaotic. So lots and lots of errors occurred due to patient intake and data management, and the consultation notes quality just plummeted as well because the GPs weren't confident in how to use it. This resulted in a higher rate of patient incidents and near misses. It also resulted in patient satisfaction declining due to lots and lots of delays and miscommunication. Features weren't fully utilised, which obviously resulted in that waste of money, and staff turnover ended up increasing. Now to Greenfield. Greenfield's practice manager engaged staff from the outset by having a little bit of a whinge session about the existing one and saying, what is annoying you about it? What do you wish it did? What's important to you as a team for our software to do? He took that information, he went away, and he ended up picking 2 packages. Came back to the team and said, these are the 2, here's the pros and cons, what do you reckon? Team voted on one, They got the software provider to come in and actually do a series of trainings. They were also filmed so that people could watch them after the fact. And people that couldn't make the training were given an hour to set aside to watch that training. They were also given access to ongoing online resources and follow-up workshops. Regular check-ins were established with the staff to gain feedback on how everything was going and address concerns, which really fostered a sense of ownership. Practice manager also kept track of KPIs like their data through Primary Sense to double check that everything was still going well. And they actively championed the change. So what came out of that was that it was relatively seamless. Obviously, there's only ever teething issues, but they were quite easily resolved. Due to the new workflow tools and the SMS recall and reminder features, they had increased efficiency in their workflow processes and a reduction in did not attends and improved patient satisfaction. Patients' practice experienced a 20% reduction in data entry errors. Everything was being coded, which was wonderful, and lots of patient engagement because of that SMS. And staff felt really empowered and motivated, which contributed to a positive workplace culture. So quickly, that's what we've talked about today. And I'm just going to leave you with one salient point. When I was a bright-eyed, bushy-tailed 23-year-old, Gary Smith and I met for the first time. And in that meeting, he told me two things. One, that Mudbrick has the world's best red wine, and he's right. And two, that we are custodians of knowledge. We are nothing but custodians of knowledge. And Gary alluded to this at the very, very beginning of his presentation as well. So I love that it bookended. And it really has stuck with me. Change is an everlasting relay, and you are responsible for your leg of the race to take on what people have done before you, learn from it, improve on it, and then set the people that are coming up after you for the best amount of success that you can. You are a custodian of your knowledge at that time, and you are responsible for your leg of that race. So make sure you run as fast as you can and make sure you set your future predecessors up for success. Thank you very much.
Thank you so much, Riley. That was amazing. Oh, you're going to even do the slides for me now. Excellent. So we'd really like to hear some questions if you have them. Riley, I do have one that was posted quite a while ago, and I'd like your comments on it because it's really, really relevant. And it's from David, and talking about change management assumes some level of management skill.
Absolutely.
Simple project management, for example. GPs may have learned such skills on the fly, but there is often little support for GPs to learn such skills compared to learning about public health, masters, all those sorts of things. I mean, we know that GPs have such a varying range of, there's so much they have to actually learn. But I think business skills are one of those things that have been under, well, it hasn't been a priority for the colleges or anyone else, but in this day and age, it really is something that GPs have to understand as well. What are your thoughts around that?
Yeah, I read this one when you popped it up. Thank you for that, David.
Mm.
And it really resonated with me because a huge part of what I do with QIP Consulting is that we support practitioners who are undergoing audits, mentoring, or education because of conditions imposed on them by AHPRA. And so many of those practitioners, their conditions come from a lack of understanding electronic health records. Because for a huge part of their job or a huge part of their time in practice, they were working on paper records. And this is just one example, but it's an example of how change management is unfortunately handled so poorly when it comes to people whose job it is not, if that makes sense. It's not their primary purpose. And unfortunately, the onus falls to the practitioner themselves and to the practice manager to work on this, but there is not the support as yet from the college, from education institutions and things like this to empower, specifically from a GP standpoint and for a GP audience, to empower this change management to come on. Obviously, you can get consultants like us to write you up webinars and things like that, and that is a service that we often provide for really proactive teams, but there isn't those CPD attached presentations out there that are needed. So hopefully with the excessive, and I keep going back to ICT because it's a really good example for change management. Hopefully with the excessive amounts of ICT changes and AI changes that are coming through, fingers crossed that some of the education institutions and the CPD homes will embrace the need for that soon. Do you have something, Gary?
Trisha, can I be so bold as to mention my new book?
Oh, Gary. Well, Riley mentioned her role. Let's mention your book then, Gary.
Now, Trisha, this wasn't a set-up question, far from it. But
No.
the reason I co-authored that particular book is exactly because of David's comment.
Mm.
And that book is around the principles of healthcare practice management, of which change management, leadership, etc., is in it. Because I think a lot of us have lost the basics, the principles of the way in which we run our practice or our business, or increasing our skill sets. And that was the driver in relation to that particular book. There's been some great feedback, David, from clinicians who have got it, because it just provides that foundation knowledge that gives you that springboard of where to from here. So I just thought, sorry, Trish, to promote it, but
well, I don't think you mentioned the name of the book, and Riley only held it up very briefly. So you better do that again, Riley.
It's actually called The Principles of Healthcare Practice Management. That's the book, and it's available on Amazon. But that's the whole reason for it, Trish. Trisha, was around the knowledge I've gained is not for me to keep, and as what, and I think that's the great thing about evenings like this, and is the knowledge management, is sharing the knowledge, and that's the way we're going. That's the only way we're going to learn. Is knowledge, as I said, custodianship is so important from there. David, thank you very, very much for putting it in the chat box.
Thank you, David. I was just going to ask Elisa if she could do it, but David's done it for us, so that's amazing.
Thank you, David.
David and I have been having a bit of a chat, and I think his comments are very useful for us too, to know where to lead this, and we can actually do some business training for GPs, which can attract CPD points. So we will be working on that in the future.
Trisha, just I want to flag with you in relation to the MyMedicare rollout strategy. There is going to be, and government have said this, there is going to be a change management framework put in place. And it will be, we believe it'll be run out through the PHNs accordingly. There will be maybe another party who will design the program in conjunction with the sector or the industry. So we won't be going blind in relation to change management concepts and principles of MyMedicare, because government are thinking about how we're going to do this now, how we can provide those skill sets, how we can provide those knowledge accordingly.
Well, I have to say that I don't want to depend on the government to do that in a timely manner, because nothing else has been done in a timely manner. We will take that on board definitely in advance. Also, I just think that Riley's presentation showed that it's actually not bigger than Ben-Hur. It can be quite simple, but the trouble is when we use all these catchphrases and words, people start to go, oh my God, that sounds really complicated, whereas it's not. It really is leading from the top down, and the top doesn't have to know exactly how to do it all. They just have to give permission for and agree with the team on doing it. So I think that's really important, because general practice does employ amazing practice managers and practice nurses to support them. So use your expertise that's in your practice already. One of my questions, Riley, was about the different levels of skills in general practice, and you did answer that too, because I was thinking of my team and the different expertise they all have. And it is very different from the perspective of how people learn, and but tailoring that is not easy, but actually it's very useful in the long term.
Yeah, and look, it requires time. It requires a time commitment that a lot of us feel that we don't have most days, and you probably don't technically, but if you invest the time for 1 hour to show the person, you're going to save 10 minutes for the next 45 days of just one question. Can I just clarify? And it's that upfront investment of time that sucks and that hurts and that you have to carve out that is going to create the efficiency long term.
Yeah. Thank you for that. I just had a question about can the presentations be sent out to the participants? Yes, they definitely will be in the next couple of days with the recording. I've just got a couple of PHN items to address, and they do go along with all of these change management issues. Everyone stopped sharing, so so I will share from now on. No one's interested in this stuff from me. So first of all, I want to remind you all about the National Health Service Directory, or alternatively, the PCA, which is the portal for registering all of your amazing information, which then feeds to the National Health Services Directory. In Victoria, finally, Melbourne, a lot of our public hospitals are actually moving to secure messaging delivery. And now they need all of the practices to have an updated listing on NHSD, which can go through the Provider Connect portal. Ideal because it's an automatic thing. Whenever you update in PCA, it updates the NHSD. It's really about patient continuity of care. Sorry, it's getting too late for me, obviously. You want to know where your patients have been, if they've been to hospital. You want their discharge summaries, so you want their discharge medications. But the hospitals are obliged to use the NHSD directory for all of those things, and unfortunately, it's not up to date. So thank you very much in advance for all the practices who are going to update their listing either through PCA or NHSD, and Northwest Melbourne PHN Communications are sending out information continually, but please contact if you need more information. Just a few messages about health pathways. So there are some non-clinical health pathways, and there's a whole lot of information. There's a whole lot of them here, if any of you feel inclined to check that out. But the important thing is that if any of your practitioners or clinical team members say, I can't get access to health pathways anymore, we have changed the access. They will be now, but by the middle of January, they won't be able to access via the shared link. It will be individual logins. So just to make you aware that that's what's happening with health pathways. And finally, Elisa, who has been my wonderful back-end support person, you don't see her, but she does amazing work there, will be sending out, has sent out a link. Well, I've got the link, but she sent out information about the survey that we'd like you to fill in. It's really important that we get your feedback on these presentations so that we can tailor them so that they meet, if they didn't meet your expectations tonight, that they do in the future. Give us ideas about what sort of things you want to hear from us about, and just give us general feedback. It's really, really important, because we don't want to be continually giving you information that you don't want. So it's really important that you get back to us on these. Riley or Gary, anything else for?
Well, there was just a quick question in the chat, but I'm not sure if the person who asked it has gone, relating to recalls and reminders and reaching certain groups. I've just put a suggestion in there for elderly patients, but David's made a really salient point regarding vulnerable populations who don't have access to tech. And yeah, my only big answer over that one is just person-centered communication, going back to the individual and going back to what format of is going to work for them, whether it's video or it's anything, be creative. And yeah, that's all. Thank you.
I just got one update, Tricia, in relation to PCA, the Provider Connect. I spoke to them last week, and they were saying that Services Australia and Medicare will be part of Service Connect, I think, next year. And I think once Services Australia and Medicare are on there, everyone is holding back until them, like Hot Docs and a lot of those others are holding back until Services Australia and Medicare. So once they join PCA, we're going to see a massive benefit to us all as one central location.
Thanks, Gary. I didn't hear that. I did hear that most of the private insurers are going to be on board within the next 6 months or so, which is also going to be useful. So it's about that. It's about the benefits, and most practices will be able to see the benefits when Medicare comes online and those other orgs. So thank you very much for that update. I really appreciate it. So any questions, and I don't think there were, that weren't answered in the chat, we will answer. And you will receive copies of these presentations. You will please do respond to the survey and let us know if there's anything else that you really need, really want. You've got relationship managers there who can support in our PHN to support you. So please be in contact. Thank you very much, everyone.